I'm Angelo Tana. I'm professor of ophthalmology and director of the glaucoma service at Northwestern University Feinberg School of Medicine. Glaucoma is a progressive optic neuropathy in which there's a characteristic change in the appearance of the optic nerve that we commonly call cupping. There's excavation of the neural rim and damage to the lamina cribrosa, which makes it uniquely identifiable than compared to other optic neuropathies like anterior ischemic optic neuropathy, for example. And there are really classification of the non-childhood glaucomas divides the glaucomas into two groups, the open-angle glaucomas and angle closure glaucoma. And in open-angle glaucoma, there is no macroscopic obstruction of the outflow pathway. In angle closure, of course, there is iridotrabecular contact or iridotrabecular adhesion that results in impaired aqueous humor outflow. Generally, glaucoma, both forms, are fairly slowly progressive disease processes, but in some patients with open angle glaucoma, maybe about 10%, there can be rapid progression, which we think of as being faster than a change in the mean deviation of the visual field of 1 decibel per year. In angle closure, the disease process tends to be more rapidly progressive, and patients can lose vision in a short amount of time. And it's more common that in angle closure glaucoma that blindness can result. The disease is very prevalent, and it's the leading cause of irreversible blindness worldwide. So, what are the risk factors for open angle glaucoma, the most common form of glaucoma? Well, intraocular pressure, higher intraocular pressure, is a major risk factor, but it's common for glaucoma to occur even in the statistically normal range of intraocular pressure. Older age is also a risk factor for glaucoma, and there is a definite hereditary component, and so family history is a risk factor. Thinner cornea is a risk factor for progression from ocular hypertension to glaucoma. Myopia is clearly a risk factor, especially high myopia. Use of certain medications like corticosteroids can increase the intraocular pressure. Race and ethnicity play a role as well. African and Caribbean ancestry is associated with a fourfold increase in the prevalence of glaucoma in the US population compared to European-derived persons. The prevalence is also higher in people of Hispanic descent and in patients in Asia, especially with high myopia. Certain comorbidities like diabetes and hypertension appear to be associated with glaucoma, but the association is complex. We're not sure about diabetes. And with blood pressure, we know that very low and very high blood pressure are associated with glaucoma. And typically, glaucoma is an asymptomatic disease process until very late in the disease. But the hallmark finding is optic disc excavation that you can see clinically. So the most important thing about diagnosing glaucoma is looking at the optic nerve and recognizing optic disc excavation, and then performing additional testing as needed. Elevated intraocular pressure is, of course, also important, an important component of the examination, but a normal pressure does not at all exclude the diagnosis of glaucoma, and elevated intraocular pressure sometimes does not go on to progress to glaucoma. In open-angle glaucoma, there is increased resistance to aqueous humor outflow, especially through the conventional pathway, through the trabecular meshwork and Schlemm's canal. And that reduced outflow facility or increased resistance to outflow results in elevated intraocular pressure. There's also some evidence, especially in pseudoexfoliation glaucoma, that there can be impaired outflow through the uveoscleral pathway. So the elevated intraocular pressure, or even a normal pressure that's too high for that particular optic nerve, results in gradual damage to the lamina cribrosa and remodeling of the tissue that generates the cupping or excavation of the optic nerve head. And the damage to the lamina cribrosa, we believe, results in impaired axoplasmic transport through the axons of the retinal ganglion cells at the level of the optic nerve head. Now, that results in the retinal ganglion cell body located in the retina, failing to receive certain survival signals from the secondary neuron in the lateral geniculate nucleus. And that triggers apoptotic loss of those retinal ganglion cells. Well, in general, patients who have primary open-angle glaucoma in the setting of normal baseline intraocular pressures, what we call normal tension glaucoma commonly, is a disease process that progresses on average more slowly than primary open-angle glaucoma with elevated pressures. But there are patients in whom there can be very rapid progression. And the presence of an optic disc hemorrhage, for example, is, if you will, a red flag that indicates the high likelihood of rapid progression in the near future. So that should be considered a warning sign that the patient needs to be monitored very closely, or maybe a lower intraocular pressure needs to be achieved. It's not unique to normal tension glaucoma to have optic disc hemorrhages. In fact, in patients with ocular hypertension, disc hemorrhages sometimes are present. Another difference, and it's a controversial matter, but I think there's growing evidence that in normal tension glaucoma, you're more likely to see paracentral visual field defects. So we often think about glaucoma as being a disease in which you get peripheral visual field defects, but that's really not true. It's very common to have visual field defects that are in the paracentral region. Well, steroid-induced open-angle glaucoma can occur with steroid exposure from a variety of reasons. For example, topical therapy with treatment for, let's say, cystoid macular edema or uveitis, all the way to systemic therapy for systemic disease processes. Cutaneous exposure can cause open-angle glaucoma. This is sometimes missed. I've found, for example, patients who use steroid-containing shampoos for certain scalp disorders have a very high likelihood of developing steroid-associated glaucoma. And we can't forget endogenous corticosteroids. Sometimes you can diagnose Cushing's disease because you're an observant ophthalmologist and detect elevated intraocular pressure. But with steroid-associated glaucoma, there are changes that occur in the outflow pathway. An increased concentration of glycosaminoglycans in the extracellular matrix of the outflow pathway resists outflow of aqueous humor and can cause elevated intraocular pressure. When we think about the treatment of glaucoma, I think it's really important to think about the underlying pathophysiology and trying to address it. And as we advance in the field and expand our therapeutic options, I think that the use of targeted therapies that address the underlying molecular disorder that causes increased resistance to outflow is going to be increasingly important.
My name is Dr. Courtney Bovey, and I'm a glaucoma specialist and general ophthalmologist practicing in Tampa Bay, Florida. When we look at the glaucoma medications that exist, we look at kind of a simplistic model of a bathtub. I can turn off the faucet, being decreased aqueous humor production, or I can open the drain, being increased aqueous humor outflow. As we look a little closer, we break those down in terms of where does the mechanism have the most effect. Those drugs that decrease aqueous humor production include alpha-2 selective adrenergic agonists, beta blockers, and carbonic anhydrase inhibitors. Drugs that increase aqueous humor outflow at the site of the trabecular meshwork include cholinergics, and those that act at the uveoscleral pathway by increased aqueous outflow include our alpha-2 selective adrenergic agonists and our prostaglandin analogs. When I look at that, we have different sites of resistance, and then how do I maximize kind of turning off the drain to better understand the biomechanics of aqueous production and aqueous outflow. So it's important to really understand our patients and aqueous dynamics to best approach the problem of decrease in intraocular pressure. We have many mechanisms in terms of how do we decrease IOP in a glaucoma patient. As we break it down, we can look specifically at different classes of medications. First, being alpha-2 selective adrenergic agonists that are dosed 2 to 3 times daily. These have a very robust IOP lowering and can include adverse events of dry mouth, headache, follicular conjunctivitis, and drowsiness. Important to note, avoid in children and those taking MAOI inhibitors. Beta blockers are dosed 1 to 2 times daily and have been the gold standard of which the American FDA kind of approves different glaucoma therapies. These have a 20 to 25% decrease in intraocular pressure and can include adverse events of respiratory and cardiac issues, including bronchospasm, low heart rate, exacerbation of CHF, low blood pressure, and changes in blood viscosity. Please use contraindications with patients with underlying respiratory and cardiac issues, including COPD, asthma, low heart rate, CHF, and first-degree heart blocks. Carbonic anhydrase inhibitors are a very effective class of medications dosed 2 to 3 times daily. These offer a 15 to 20% decrease in intraocular pressure. Adverse events can include corneal edema, keratitis, punctate corneal changes, and a metallic taste in a patient's mouth. Use contraindications in patients with known sulfa allergies, kidney stones, blood disorders, including aplastic anemia and thrombocytopenia. As we move on, cholinergics are a very long use of glaucoma medications that are dosed 3 times a day, and they offer a 20 to 25% decrease in intraocular pressure. Because of their change on the refractive status of the eye, they can cause myopia, blurry vision, decreased pupil size, and headache. Commonly, patients may report a brow ache with installation. Use caution because this can disrupt the blood-aqueous barrier. So use caution in anyone with neovascular, uveitic, or malignant glaucoma. And a very commonly used class of medication are our prostaglandin analogs. These are dosed once daily and have a very robust pressure lowering of 25 to 35%. These increase the permeability of the uveoscleral pathway and can include adverse events like lash changes, periocular pigmentation, hyperemia, burning and stinging on installation. And contraindications can include macular edema, reactivation of herpetic disease, and acute uveitis. It can be challenging when we decide, what is our first line therapy for patients. Commonly, when I see a new patient or somebody needing a lower pressure that has not previously been on medical therapy, a prostaglandin is usually my first line treatment due to its once a day dosing and very robust pressure lowering. Secondly, a commonly used medication is our beta blocker due to their very low side effect profile on the ocular surface. We had several mechanisms in which we use to treat glaucoma by lowering intraocular pressure. 2017 marked a very exciting year with the launch of 2 newer mechanisms that really offered exciting opportunities to better treat patients with glaucoma. One of the first agents was our prostaglandin with a nitric oxide donating moiety. This is latanoprostene bunod and is metabolized to nitric oxide donating moiety and latanoprost acid. This really exciting class of pharmacology works in a couple different ways to better lower pressure above and beyond our standard prostaglandin. This increased aqueous fluid outflow at the site of the trabecular meshwork and increased the permeability of the uveoscleral pathway. What makes this medicine so interesting is that it has a nitric oxide donating moiety. Nitric oxide is a commonly found component to our human bodies, but it causes vasodilation and is a potent neurotransmitter throughout our bodies. When applied to the eye, it causes vasodilation and can really increase the aqueous dynamic flow to better regulate intraocular pressure. It's important to note that glaucomatous eyes have a decrease of 40% of nitric oxide compared to eyes without pathology. As we look at another class of medication, the ROCK inhibitors or nortarsidil, it's very important to note that this is another really exciting class of medicine. Why is this so exciting? Because it really addressed the lowering of intraocular pressure differently than our standard mechanistic approaches previously described. Our ROCK inhibitors are combined with a norepinephrine inhibitor to better lower pressure, acting at 3 distinctive sites that increase flow through the trabecular meshwork, decrease episcleral venous pressure, and decrease aqueous production. This kind of unique mechanistic approach really offers a better lowering of pressure, sometimes to latanoprost alone. When we look at the efficacy and safety of our newer topical therapies, it's important to note that these are really effective in clinical practice, kind of because they have that above and beyond effect compared to our standard mechanisms. When we look at latanoprost Bunode, this is dosed once daily. And I think, in clinical practice, medications that are dosed less really have a better effect because it's easier for patients to remember. Something simple in clinical practice I describe as, for a patient, we brush your teeth every evening before bed. So go ahead and put your medication by your toothbrush, brush your teeth, put your medication in, and go to bed. So that simplicity really, really increases compliance, which thus has a better effect on lowering pressure. Like I described, latanoprost Bunode, dosed once daily, has a 25% reduction in intraocular pressure. Important to note, select adverse events are similar to those of prostaglandin, including contracturemia, irritation, and pain on instillation. When we look at nortarsidil, it is similarly dosed once daily and really has that additive effect of improved compliance due to a simplicity of dosing regimen. It offers a 20% reduction in intraocular pressure and has side effects including contracturemia, corneal verticulata, conjunctival hemorrhage, and pain at instillation. No contraindications were reported for either class of medicine. As we look at latanoprost Bunode, it has a 1.2 drop in pressure compared to generic latanoprost, which, a lot of times we can think about if a medication isn't working, what would be a more effective class of medicine that has a similar dosing regimen. And a lot of times this offers that extra pressure lowering. Nortarsidil is important to note that it is metabolized to nortarsidil M1, which is 5 times more effective than nortarsidil alone. In compared to a similar agent, ropacidil, that was approved in Japan, nortarsidil had a lower IOP compared to that Japanese product. When we look at these two therapies, really important because, they really offer a different mechanistic approach than we were used to. And this, really adds more opportunities for us to lower pressure kind of more effectively. And, for those patients that had, allergies or intolerances to previous mechanisms, additional therapies that might be effective. The world of glaucoma has really evolved in terms of we have so many new and exciting surgeries to offer our patients, methods of delivery, and mechanistic approaches to better target patients with glaucoma and ocular hypertension. As we look at these new classes of medicines, it really offers a great opportunity to do better compared to our standard therapies. It's common that in a busy glaucoma practice, we see many patients that, for some reason have developed an allergy to our alpha agonist. They may have experienced a tachyphylaxis or decrease in effect of our beta blockers. Sometimes they might have allergies that might preclude them from using a sulfa-based medication. So these new therapies really offer a great kind of opportunity for us to target these patients that have had problems with those previous therapies. It's exciting because these therapies a lot of times might be that extra effect that sometimes can keep that challenging patient out of the operating room as well.
Hi, everybody. My name is Joe Panarelli. I'm a professor of ophthalmology at NYU Langone Medicine. I practice glaucoma and take care of both pediatric and adult patients. I think in general, when we're talking about starting patients on treatment for glaucoma and we're talking about medical therapy, I think really it's a no-brainer for us. Really, first-line treatment is prostaglandin analogs, and I think there's lots of evidence out there to support that, and various recommendations from governing agencies that suggest this is the most appropriate first-line treatment. Now, that doesn't mean that's the treatment we're going to start in every single patient, and there's a number of reasons why. Whenever I have a new patient who is sitting in front of me, I often like to have a full discussion with the patient and sort of ask them, what they're looking for in terms of, treatment goals. Are they somebody who feels they can take medication daily? Are they somebody who's looking for maybe other ways to control the pressure that doesn't involve topical administration of a drug? And, thankfully, as a field, we've come a long way, and we now do have several options available to our patients aside from medical therapy. And so I think that's what I start off with first, is really deciding whether we're going to go with a topical agent or some other treatment modality. I will say, though it is great to have so many different treatment modalities available to us, medical therapy is still probably what I go to first in the majority of my patients. And the reason is consistency. When we're talking about starting a prostaglandin analog, I find that it gets me about a 25 to 30% reduction the vast majority of the time, and it really does have a very favorable safety profile. Some patients may experience some transient hyperemia, while others will note some eyelash growth. The ones that are a little bit more concerning to patients are some of the hyperpigmentation issues we see with some of the periocular skin, as well as long-term use leading to periorbital fat atrophy. And I will say that probably earlier in my career, these were not as big of concerns, but as I've now had patients on prostaglandins for years and some even close to a decade now, I start to see that some of these cosmetic side effects are real and they are bothersome to the patient. So if that's a concern, I will look to other topical agents that we have. And probably what I jump to next are topical beta blockers, because again, we've just used them for a really long period of time and have really good success. There are some systemic considerations, but for the most part, they are really well tolerated. And there are other groups of medicines, such as our carbonic anhydrase inhibitors and our alpha agonists, and even a newer class, the Rho kinase inhibitors, that are definitely reasonable options in certain patients who maybe the aforementioned medicines are not suitable for. But, I really think it's a mix of things that you have to take into consideration. You have to think about, what are your goals? What are the patient's goals? What are the side effect profiles? What are the costs? So these are all things. I wish it was just something as simple as a one-word answer to this question, but really there's a lot that goes through our minds in the several minutes that we are talking with our patients about starting them on lifelong treatment. And I think that's what you have to remember. This isn't a one-week course of antibiotics. When you start a patient on a medicine, this is a long-term deal, and it's a big deal for a lot of patients. I think for the majority of our patients, we do see that over time, they're going to require more than a single agent to control their glaucoma. And I think that's really the art of what we do. We are trying not to overtreat some of the patients who have mild disease, but we also don't want to undertreat some of the patients with more severe disease. And that really is the challenge. I think the majority of our patients that have true progressive disease end up needing multiple agents. And these are patients where you're starting to notice changes to the optic disc or even visual field loss. And so, I think if I start a patient on a prostaglandin analog and they are not at their target initially, I will consider switching to another agent in the same class, or potentially switching from a generic to a branded medication to try to see if I can get a little more bang for my buck. If the patient's been on a prostaglandin for a considerable period of time and are now proving that they are not well controlled, then it's time to up our game. And for those patients, I will think about either going to selective laser trabeculoplasty or thinking about adding a second agent. Now, adding a second agent is something that I have sort of differed in my practice over time. I would say when I first came out of fellowship, I was a little more of a purist. And when I started a second agent, it was often a single agent, such as a beta blocker, once in the morning. I think now, depending upon the severity of disease, for some of my patients who maybe are presenting with more significant disc damage, I will jump to adding a combination agent more quickly. And I might even dose it just once a day in the morning. But, I think you really have to look at the patient's age, you have to look at their compliance, and you have to see where you need to get to and how quickly you need to get there. One of the biggest struggles is trying to achieve that target IOP while doing it without affecting the patient's quality of life. And I think that, again, has become more and more important to me as I've practiced longer. I see a lot of my patients coming in and I ask them to go over their medications, and they're taking out 3, 4 bottles of medicines, often with the caps mixed up. And I have to tell you, it's got to be hard for these patients to be administering somewhere between 8 and 14 drops a day. And when you talk about spacing and the side effect profile, it can be really quite a burden for our patients. Now, for those that have significant visual field loss whose IOP is controlled, I think that is a burden we just have to accept. And a lot of times I just sit and talk with the patient and let them know that, hey, I know this is not ideal, but it's keeping you preserving your quality of life and your independence. And, this is what we have to do. Now, for many patients, they will tolerate some degree of hyperemia. They'll tolerate some degree of foreign body sensation, knowing that if the pressure is controlled and it's keeping them from losing further vision, then it's worth it. And that's not everybody. And I will tell you that, the longer patients are on medications, the more they start to feel some of the wear and tear from the years of topical administration. Whether it's the preservative in the medications or the agent themselves, they really do some damage to the ocular surface. And so, I think it's really hard to sort of balance all of that. And one of the bigger concerns I have is that there really is a law of diminishing returns. I find that really my definition of max medical therapy has changed over the years. When I came out of training, and I keep hearkening back to that, but it's amazing how your practice changes, every 3 to 5 years. But when I first started practicing, I'd have patients on 3, 4 agents and even maybe an oral agent to control their pressure. But I really have seen now that that's really not true control of the disease. That's really, barely putting a Band-Aid on the problem. And so I find that once I get to 2 bottles, which is typically 3 classes of medicines, I'm starting to think more about what I need to do long-term for the patient. Because when you start adding that 3rd or 4th line agent, a lot of times you don't get kind of the same return on investment. I find that sometimes with Rho kinase inhibitors, when I add them later in the algorithm, sometimes I can get a little more beneficial effect. But for the most part, it is really hard to get patients down to target, once they're on, 2 or 3 classes of agents. And I think that's when you start needing to have the discussion about more aggressive intervention, often in the form of surgery. I think thankfully as providers, we have lots of different topical therapies, that really are well suited to our patients. And from an efficacy standpoint, there is not the most robust data, especially when you compare them head to head. But, even individually, most of the trials are comparing that combination agent to the individual components. And for a lot of these medications, we're often, comparing and looking at small differences in terms of, percent reduction in IOP when you're trying to sort of extrapolate from the data some meaningful conclusions. So I think for me, for the most part, whether we're talking about a beta blocker combined with the CAI or a beta blocker with an alpha agonist or even an alpha agonist with the CAI, when you're comparing them across the board, most of them are going to get you very similar IOP reduction. Where things may differ are in the side effect profile and the tolerability and even cost of these medications. So I often will say that a lot of times it does come down to that, being perfectly honest, patients will take medicines, that are affordable. So I think you have to look at that and you really want to be able to see what medicine can I get into my patient's hands. Now, the one thing I will say is that there is a new class of medications or a new medication that actually combines a prostaglandin analog with a Rho kinase inhibitor. And that is maybe a different type of combination agent. And where you use that in our treatment algorithm is, I think, still yet to be determined. And so while I may have said that some of the other fixed combination therapies are fairly interchangeable. This is kind of a little more of a novel medication. And I think for many of us, we try to use it first line because we hope that we can get down to our target IOP a little bit more quickly. But, that is one of the harder medicines to compare to the other fixed drug combinations, just because in real life practice, we may not use it the same way. We talk a lot about this explosion in the field of glaucoma that we had over the last decade, and I do think it's wonderful, but I do find it does make my job a little harder day to day, because it is not just as simple now as, say, writing for a prostaglandin analog or writing for a combination agent. It's nice to have, other treatment modalities, because I do think we are treating this disease longer. We are diagnosing it earlier. Patients are living longer. So we do need to utilize all of our weapons. And so now we have things like laser trabeculoplasty, and we've had it, but now we have even better evidence for maybe moving it up in our treatment algorithm. We have intracameral drug delivery, and I think we're just at the forefront of that. We don't even know quite how to fully utilize that potential, but I'm excited to see where that field sort of evolves in the next several years. And then we have MIGS, microinvasive glaucoma surgery, and I think that is something where the big teaching has been try to use that earlier in the treatment algorithm to try to get the disease more stable before these patients progress and need some of those more aggressive surgical interventions. And so it's easier said than done. Nice having a lot of options, but I think what we still need is we need even better testing modalities so we can determine the rate of change and we can pick what is the most appropriate treatment strategy.